So, good evening to all the physiotherapists from this part of the world, and good morning to all the physiotherapists from the western part of the world. Asian Physiotherapy and Research Institute and Sarvajanik College of Physiotherapy jointly organizes this webinar on the topic Chronic Pain is Not All As It Seems by Dr. Devdeep Ahuja. On behalf of Asia's largest physiotherapy center and one of the premier institutes imparting education in physiotherapy from Gujarat, we welcome Dr. Devdeep Ahuja, who is a renowned physiotherapist from UK. So he is a co-founder and clinical innovation director of RTW Plus Ltd. He's got a strong background focusing more in the areas of complex trauma, amputations and chronic pain. He has a doctorate degree in which he focused on factors influencing adherence and attendance in musculoskeletal physiotherapy. He has more than 30 conferences of international presentations, and he as well as runs training courses for healthcare professionals in workplace rehabilitation. He is responsible for clinical leadership for a multidisciplinary team of healthcare professionals. He is passionate towards research, innovation and development in the area of rehabilitation and healthcare services. He has won various awards from CSP, VRA and various other industry bodies in the areas of research and rehabilitation practice. He is the immediate past chair of Physiotherapy Research Society UK and presently the director of CMSUK and chair of the research committee. It's a pleasure to have you with us, Dr. Devdeep. And before switching on to the resource person today, I'd like to request the participants to mute yourself so that we can continue without any disturbance. And you're welcome to put your questions in the chat box, which will be discussed at the end of the session. For all the participants, a small note. A link for the Google form will be provided in the chat at the end of the session, which you need to fill for the certificates. Do not drop any messages in the chat box for certificates in between. The stage is all yours, Dr. Devdeep Ahuja. Good morning.
Hi, thank you. Can you hear me?
Yeah.
Okay. Are you able to see the screen?
Yes.
Sorry, there's a lot of static, so I'm not quite sure whether you can see my screen. Is it the presentation that you're seeing at the moment?
Yes, we are able to see you.
Perfect. Okay. All right. That's great. Right. I shall get started then. Let me just bring. Okay. Yes. Thank you so much for your introduction. That's too many words there, but yes. Thank you so much for your introduction, and thank you, Sagar, and all the other organizers for inviting me to share my thoughts and experiences of working with chronic pain patients. When I sort of started to think about this webinar, I thought that I'd be talking about some of the advanced concepts in terms of chronic pain and how it impacts us and how we can therefore understand it, our understanding of it, and how it has changed over the last 20 years and such. But the questions that were given to me during the registration form, I felt like there was a need for us to really go back to the basics in terms of how does chronic pain develop. I think that was one of the most common questions that was put in the form there, and also then talking about manual therapy and electrotherapy and how can we use those to manage chronic pain, can we use those, are the outcomes and effectiveness of those. So I thought I'll just scale back a little bit and start from the very beginning and talk about pain and in general, and then how does that develop into chronic pain. And I'm sure all of us have seen patients who had physiotherapy, who then go on to get injections. Some of them go to surgery, some have yoga, massage, they go to acupuncture, they go to chiropractors, they go to mindfulness training. They've tried everything, every single thing. And yes, they do get some relief. Sometimes it can last minutes, sometimes hours, sometimes a few days, weeks. With injections, it might be a couple of months, 3 months, but the pain does come back. So every time they have hope with the new treatment that they're going to try this and that and the other, and it's going to work and it's going to help, and they have hope. And then as that treatment fails, the pain returns, they feel devastated about it, and it is like it's just an endless cycle. How do we move forward from there? And I'm sure we've all sort of seen these kind of patients. We've all gone through this kind of process. And what we're trying to do today is unpack that and understand why that chronic pain doesn't sort of seem to end, why it seems to come back again, and how can we target our interventions so that we can provide long-lasting support to these people, and we can support them in terms of being able to regain their life and restore quality of life. I think that's what we need to be talking about. Right, so let's get started. Just before we start, obviously, the mandatory disclaimers. I do present seminars and workshops, and I'm not going to be sort of selling here or anything, so I'm not promoting any of those things today. My company, RTW Plus, does provide a chronic pain management program, and we do provide rehab services in the UK. And again, I will be touching upon the Restore program, but that is just to highlight the principles upon which our chronic pain management program is founded, it's based on. I wouldn't be promoting the program in terms of trying to sell anything to you guys. So just with those mandatory things out of the way, so those are things that I will not be talking about. But what I will want to talk about is understand the development of chronic pain. How does chronic pain develop? What is the mechanisms behind it? How does it actually work? So I'll look at all of those aspects of the development of chronic pain. And then as we move on, it will become clear. It will become much clearer to us why traditional approaches may not work for chronic pain. So yes, we could think of lots of different things. We could think of manual therapy, electrotherapy, exercise therapy, all of these things. But why just doing traditional approaches doesn't work? So that's the second thing and I think as we go through the whole presentation, it will become clear that is probably not the answer, or that's not the only answer to the problem. But then we're going to look at what does actually work. So what can we do for these people? How can we help them? And then finally, I'm just going to give a brief overview of the digital program, the Restore program that we are providing to our chronic pain clients at the moment. So let's get started. First of all, it's a very exciting time at the moment. So just recently, the IASP, which is the International Association for Study of Pain, that has updated the definition of pain after nearly 40 years. So they've changed the definition, and it's an interesting definition. If you read it here, I'm not going to read it for you guys. It's just there. But we could probably spend a full day just talking about this definition of pain itself and trying to understand what it actually means and what it means in terms of what is the implication for our practice as well. So if you think about it, it is a sensory and emotional experience. So pain is an experience, that's one thing, and it's sensory or emotional. So it's both of those components. It's not just a pain sensation, it's an emotional experience as well. So that's the other element to think of. And then the other bit is actual or potential tissue damage. So there might not be actual tissue damage. So we might not have an injury for us to be in pain. Our traditional thinking always been, well, you get injured and therefore you get pain, or pain prevents you from injury, that kind of thing. But now what we're saying is that there might be no actual tissue damage. It might just be potential tissue damage, or it might just be the thought or the resemblance of the association with potential tissue damage that might cause pain as well. This definition is sort of supplemented by a few notes from IASP. And again, I'd encourage you all to read this paper. It is open access. It is available free of charge, so you can download it and read this, and read what this whole sort of definition of pain means, and what the whole sort of explanation of it, rather than just looking at it, just the definition itself. But the important thing is now there is a recognition that it is not just the biological factors. It's not just our physiology. It's not just our body that is the responsive. That is not the physical side of things is not the only aspect that's important in pain. There's a recognition of the psychological and the social factors as well that are really important in terms of being able to understand pain, how it works, and how to therefore address it. And also, pain and nociception are different phenomena. So we'll go into nociception a little bit later on in the presentation. But pain is not just an output of the sensory neuron. So there's a lot more stuff going on than just the sensory neurons and the sensory input that we get from out here. And then it is a learned concept. So pain is a learned concept. We can learn over a period of time based on our experiences, based on past history, based on our output. All of those things influence our experience. All of those things influence how we perceive pain. And then it should be respected. Pain is real. So even though we're saying that yes, there are biological and psychological factors and all of that, but it is never, it's not just an easy thing to say, oh, it's all in your head. It's not. It is a real feeling that person is getting. It's a real perception that the pain, unpleasant perception that the pain is that the patient is getting. So pain is real. And then it can have an adverse impact on function and social and psychological well-being as well. So that's just the notes on the IASP definition. But I think the key takeaway for me here is pain is a personal experience. It is a real experience that everyone feels, and it is also associated with the biological, psychological, and social factors. So it's not just about our physical pain symptoms. Just a brief overview of the pain mechanism. So again, I'm not going to go into too much of detail around the anatomy and history and all of those kind of things. What I'm going to try and do is just break it up a little bit so we understand where we are sitting and what we're going to be talking about today. So the first one that we have is nociceptive pain, which arises from the actual or threatened damage to the non-neural tissue. So this is all about the MSK pain, the non-neural tissue. It's also the visceral pain. And it is a normal physiological response. So anytime you have an injury or whether there's a harmful stimulus, so it may not be an actual real stimulus, it might be a perceived stimulus, and it can be mechanical, chemical, or thermal. Any of those can cause pain, and that's the nociceptive pain. So the somatic pain is the one that's MSK, and it's the cutaneous, all the skin receptors and such. Whilst the visceral is the one from the hollow organs and the smooth muscles inside the body. So that's the visceral pain. And then the neuropathic pain is the one that is evoked by the sensory stimuli, which is represented by the typical innervation territory of that nervous system. So it can be peripheral or it can be central. So you could have peripheral diabetic neuropathy is a classical example of neuropathic pain, or central is like spinal cord injury pain subsequent to stroke or ischemia or multiple sclerosis, for example. So all of those are examples of central neuropathic pain. And the last category is the nociplastic pain. So now nociplastic pain arises from altered nociception. So that it is about altered input into the body despite no clear evidence of actual or threatened tissue damage. So we're not looking at real tissue damage, or there's no evidence that there is any actual tissue damage or there is even threatened tissue damage or perceptual tissue damage, and that's what is nociplastic pain. And patient can have a combination of these, so they can have a combination of nociplastic pain and nociceptive pain, or they can have a combination of nociplastic or neuropathic pain as well. So it's a combination. It can vary. It can be layers of each, and I'll show you the layers in a minute as we go along further. For the first time in ICD-11, that's when we've got this actual entity called chronic pain. So in the first 10 iterations of ICD, there was no coding for chronic pain on its own. So chronic pain was just a subset of other things. But for the first time in ICD-11, chronic pain has been categorized and coded as its own code. And there are two main kinds of chronic pain, really. So you've got the chronic primary pain and then the chronic secondary pain syndrome. So chronic secondary pain syndromes and chronic primary pain. So primary is the one pain in one or more regions of the body that persists for more than 3 months, and that's the important thing. 3 months is taken as sort of the cutoff criteria, and it is associated with significant emotional distress or functional disability, and that it cannot be better accounted by another chronic pain condition. So there is no underlying chronic pain condition. So you just have pain and you don't really know what is causing it. So it's a dysfunction. And this is a new definition. It applies to chronic pain symptoms that are best conceived as the health condition in their own right. So you've got the CRPS, for example. That's an important one, and that is considered in these. But also you could have visceral pain for no other reason, and the primary musculoskeletal pain as well. As we move on forward, the chronic secondary pain syndromes are linked to other diseases. So you have cancer, for example. Cancer causes a lot of pain, and subsequent to either the etiology of cancer or subsequent to the pain associated and the intervention, the treatment, the chemotherapy and radiotherapy and all of those, there's a lot of pain, and that is the secondary pain to cancer. So it is cancer-related pain, so it's chronic cancer-related pain. And similarly, you have the chronic post-surgical pain, chronic neuropathic or chronic musculoskeletal pain, and such as well. So that's just the high-level definitions and understanding of what chronic pain is. Just talking about chronic pain in India, I mean, all across the world, chronic pain is a major issue. But there's been a couple of studies that have been done in India and that have looked at the prevalence of chronic pain in India. So it's reported to be in the range of 13 to 19% of the population. So if we think of it as 19%, that's like 1 in 5 of everyone who's 1 in 5 of everyone in India has some form of chronic pain, and it can be of varying intensity. So it's not that 20% or 19% of the population is disabled, but it is about they continue to suffer with that. So over 220 million people in India suffer with chronic pain, and most likely it is underreported. We don't really know, and it is undertreated because a lot of the population is still in rural areas, and the access to healthcare might not be optimal. So I'll put the references there for you guys as well in terms of looking at these. So let's just now start to think about how does chronic pain develop. So we've said, yes, chronic pain is something that lasts more than 3 months, and it carries on. It could have a physical basis, it could not have a physical basis, and all of those. But how does chronic pain develop, and what's our understanding of pain? So I think I'm just going to go back to our previous understanding of pain. So when I was doing my undergrad, for example, this is what we were taught, that nerves send a message to the brain with intensity equal to the nature of injury. So you feel injury, or you feel a risk of injury, and there's a danger, and the nerves send the signal to the brain. Brain responds accordingly. We believe that information that comes from the nerve, and then we just action accordingly. And that's the work of René Descartes, and any of the discussions around pain and chronic pain would not happen without this initial model. This was proposed in 1664, and we sort of carried on till about 1990s with this same understanding of pain. But the last couple of decades have been really interesting in that we now understand a lot more about pain neurophysiology, about pain neuroscience, how it actually works, and now we know that pain is weird. It doesn't follow the exact rules. It doesn't follow the exact state. As we said in the definition of pain as well, there might not be an actual injury. So whilst in the first graph at the right top left, we see there's a direct association between injury and pain. So the bigger the level of injury, the higher the level of pain. This might occur in acute pain, but usually it doesn't, because even in acute pain, our responses will vary according to our experience, belief, attitudes, and all of that. And I'll come back to that a bit later on. So what happens even if there was a direct relationship, and you'd see, okay, you provide that intervention, so you provide your manual therapy or you provide medicine, and the person takes the medicine, the injury heals, and therefore there's healing, and the pathology goes down and the pain goes down as well, and that's depicted in the top right graph. But the bottom two are the ones that are really, really interesting. These are the ones that are really interesting for me. So in the third graph, we see there's a lot of pathology. There's a lot of pathology, but there's very little pain. And this is quite common as well. So if we, I mean, this is quite an interesting one. So if we take an MRI scan, my MRI scan, for example, if we take my MRI scan, you'd probably see a lot of this degeneration. You'd see a lot of degenerative changes. You'd see all sorts of pathology in there. But I don't have any pain. I don't have any issues at all. I walk, I run, I do activities. My functional activities are fine. I'm working. No problem at all. How does that match with our initial understanding that you have an injury and therefore the body responds with pain? It doesn't fit with that. But also, if you think about the soldiers in the war, I mean, there's a story of a World War II veteran who had some routine chest X-rays done, and they revealed a bullet that had been lodged in the neck for 60 years. He had that bullet in his body for 60 years, and yet he never knew. That's weird. That's strange. How can that be possible? But we also experience high-level pains from simple paper cuts. So that's the other end of the spectrum, that you can have just a simple cut and you will experience really high levels of pain. How does that fit in? So the fourth ones are even more interesting. So there is very little pathology, but there is very high level of pain. So these are the ones where the initial injury is healed. So for example, you take a foot and ankle fracture, a very common one, foot and ankle fracture that sort of then leads on to development of CRPS. So when you do an X-ray, there is no pathology. The bone is healed. There is nothing else going on. There is nothing in the tissues. But the patient continues to experience really high levels of pain. And there might be other instances where they've not ever had a major injury in the first place as well, and yet they continue to experience severe pain. So this doesn't really fit in with our understanding of our traditional understanding of pain. So before we can understand how can things go wrong, it's just quickly I will go through what exactly happens. How does the brain perceive our pain? How is pain generated? Now, pain serves an important purpose. Let's not. There's no two questions about it. There's no doubt about it. Pain serves a really, really important purpose. It is an important safety mechanism. So think about patients like with the diabetic neuropathy, for example. That's a really good example. So they can't feel anything, so they lose the sensory capacity, and therefore they don't feel anything in their feet, for example, in their legs. And so they might get a bit of injury, a pinprick or something, and the foot gets injured. It can get infected. They might be generating pain, but they can't feel it. There's no sensory feedback going into the brain, so the brain doesn't think that there's any danger at all, so there's no pain generated, and therefore they're not able to address it, and it spreads, and they finally need an amputation. Now, if I pinch my finger here, the nociceptors, the information will travel from the nociceptors. It will travel all the way to my spinal cord, where it interfaces into the spinal thalamic tract, and it ascends to the thalamus. Now, thalamus is like the 999 center, 911 center, whatever number you use to call the emergency services. It's like our emergency services number, and it goes there, and thalamus is the one that then distributes the signal to all the areas of the brain that need to know that there's a danger, something's going wrong, there's a noxious stimuli that is coming in, and everyone needs to know about it so they can respond appropriately. So we have amygdala, for example. It's a fear center. It helps us to understand how afraid we should be of any stimulus and how we should respond. And then it's also sent to hippocampus. So what does the hippocampus do? It's responsible for retrieving and making memories, and it's going to go and think about our past experiences and say, oh, whether this is the pain, whether there's a stimulus that we should be worried about. And then thalamus also sends a signal to the limbic system, and the limbic system is the one which helps to decide how important it is to take evasive action. So if we are busy, if we are busy and we are really focused on something else, like we are running, sprinting or race or something, we might not feel the pain at that time. For example, is soldiers in the wars. I mean, some of them didn't even realize that they've had their foot amputated or their hand amputated or something, And on the other hand, if we are sad and if we're depressed and we're just sitting there brooding, then we feel a lot more pain. So signal then, so we've talked about it goes to the it goes to the thalamus is sending signals to the hippocampus. It sends it to the limbic system. It then sends the information also to the frontal cortex. Now, frontal cortex is the one where we have our rational thinking, and here is where we interpret the data that is coming in to see, oh, what's going on? What are we going to do? How is this? That's where we create our action plan. That this is what we're going to do about it. And then based on that, we provide the feedback back to the thalamus. So the forebrain and all the parts of the brain then provide feedback to the thalamus and to the somatosensory cortex. And the cortex is where we actually perceive pain. So all the areas of the brain provide a signal to either magnify or diminish the activation of the somatosensory cortex. And that's the important element. So the brain can respond by activating several systems to get us out of the danger. So if there's a danger, whether it is perceived, whether it is actual, whether there's a pinprick going on, or it's just a thought, you can see that you will have the activation of the sympathetic nervous system, which increases your heart rate, which mobilizes energy. Can you see when we are really nervous or we're sensing danger, we can have our palpitations and sometimes even sweating and all of those things. So that's the sympathetic nervous system. And then you have the motor nervous system. So you move our hand away from the fire or hot object or whatever it is, whatever the noxious stimuli might be. And then the endocrine system, the pain production system, the immune system, all of these systems then kick in. So they are at a really heightened and activated state at that time. So the body's alarms are going off. We are in danger. We need the support. We are in danger. We need to activate something. We need to do something about it. That's how our pain is generated. That's what the normal process is. And these systems will work really hard for you, but they're really good at working in this fashion for only short periods. So during pain, the activity of the systems is like a sprinter. So you're sprinting hard, high levels of activity, 400-meter run or 1600-meter run, and that's it. But if you're going to try and run a marathon, you can't have a sprinter running at that sprinting speed for the full 26 miles that the marathon is. And that's where the problems start to happen. So we do have a dynamic system that adapts and updates based on the available information in the environment for that person and in that society to see, okay, what is the reaction that we got to give here? But sometimes the system backfires. But just before we go into the backfiring, though, I think there's a couple of other concepts that are really important. One is allodynia and the other is hyperalgesia. And both of these are sort of the alert state, the activated, the alarm state of the body. Now, in a normal person, in a non-injured individual who doesn't have altered sensation and who doesn't have the heightened sensations and the alarm systems going off, we will perceive the heat stimulus as painful at about 43, 44 degrees. So if we put a hand into 38-degree water, so we have our showers at about 38, 39 degrees, 40 degrees as well sometimes, and we're fine. We don't really feel the pain. So we start to feel the pain at about 43, 44 degrees. And as the stimulus increases, the pain starts to increase. So you'll see that dark blue there, that it starts to go up. And that's the normal reaction. So it sort of goes in the normal parabola form. And before 44 degrees, it's just considered as an innocuous stimulus, and therefore it doesn't invoke a pain response. But once we're injured, the pain response is elicited much earlier. I'll give you an example. A few days ago, well, a few weeks ago, I think it was about four weeks ago or something, I was on the phone call and I was trying to cook something, and I put my hand on the cooker and it was really hot and I burnt my thumb. And I didn't really feel it at that time because I was on the call and I was talking to someone, and I just carried on talking for a few minutes, about 15, 20 minutes. And then once I finished, I started to feel the pain. I was like, oh, I hurt it. And I put it under the cold water, and obviously once you put it under the cold water, the pain goes away. But it was really that state is the hyperalgesia. If I touched it, it was really sensitive to touch. And I went to take a shower, and normally I would take a shower at about 38 degrees or something like that in terms of the water temperature. And it was really, really painful. It brought on the pain. I had to go out and I had to put it again in iced water, and that took the pain away. And that's hyperalgesia. That is hyperalgesia. So whilst it was previously that water wouldn't have felt hot to me, it was very painful on my thumb at that point of time. And then there are times when the things that used to hurt now hurt more. That is what hyperalgesia is. But there are areas that things didn't hurt before and they start to hurt. That is allodynia. So previously innocuous a thing that just starts to hurt is called allodynia. Now, both of these just mean increased sensitivity. That's the important thing. Both of these just mean increased sensitivity. This means that touching the skin or slight temperature change might cause danger messages sent to the brain, and the brain responds with pain. So like my example, I put a little bit of hot water on it and the pain just went off the scale. And then I put it in cold water and the brain thought, oh, it's fine, it's not hurting anymore. So that hyperalgesia was addressed, and therefore we weren't feeling the pain. So when an injury happens to this person, this is a really, really good article. If you guys have not read it, I'd recommend everyone to read this. This is really good way of teaching patients about chronic pain and what is happening with their body and what is happening with the systems. So when an injury happens, there are obviously issues in the tissues and the pain in the brain, and the tissue damage can cause the local inflammation, which makes neurons more sensitive, promotes healing in the short term. Yeah, but all of the tissues have a healing time. Muscles will heal really fast. So if you injure your tongue, that will heal much quicker versus if you have a bone fracture that takes a few weeks, a couple of months. And once the healing time is passed, they don't get another chance. And this is the important thing to remember in chronic pain. Once the healing time has passed, the tissues don't heal any further from there. I think that's the important element to remember. So in line with current epidemiology, in approximately 1 in 4 people, the alarm system does not calm down after ramping up. So what's happened is we get injured, the body's alarm system goes off, all the systems are working hard to protect you, save you, and usually as it heals, the alarm system will calm down and the normal sort of excitement level, we return to that normal excitement levels. But in 1 in 4 people, this does not happen, and it just remains extra sensitive. That's where the sensitivity, the sensitization, that is the sensitization that we talk about. So here we go. Just talk a little bit more about it here. Before pain, so if we didn't have pain, there was a normal excited level, and there is a lot of room for activity. So extrasensitive system is a big reason why we are still experiencing pain. So before the onset of pain, the alarm system has lots of space for activities. We can do more movement, we can do run for half an hour, run for 1 hour, run for 3 hours, depending on our capacity, whatever. But then once it is sensitized, once it becomes extra sensitive, there's little room for activity. Now only after 5 minutes of walking, the alarm system goes off because the brain is perceiving that danger. And that's the issue. So this metaphor of nerve sensitization gives us a very different paradigm about why we're still hurting. That's an important element for us to understand, that when the pain is persisting, the alarm system of the body becomes more sensitive. So the messenger neurons become more excitable, they manufacture more sensors for the excitatory chemicals, brain starts to activate neurons and that release more excitatory chemicals, and the response systems become more involved, and then the thought and belief come in there as well. The thought and beliefs become more involved and they start contributing to the problem as well. And then the brain adapts to becoming better at producing the pain tune or the whole of the orchestra that's going in. And then actually the nociceptors contribute less and less to the danger message that's arriving. So they're not getting the signal necessarily from the the remote part of the body. My thumb is not hurting anymore, but it's just my brain that is sensitized, my nervous system that is sensitized, and that is what's causing the pain. And if you don't manage the stress, if you don't manage that sensitization, you won't be able to manage the pain. That's the important element around understanding of the pain. So it's not just a touch, it's not just a physical injury. Our bodily experiences are shaped by a credible and believable evidence that is present, and it's just not the sensory information. It's not just about the external sensory information, how we will get the pain. It is well known that there are a lot of people who just need to think of the pain or think of the movement that is going to cause pain, or watch someone else do it. I mean, I've seen patients who will tell me, oh, someone else was doing this offending movement. This is the movement that's really painful for me, and I watched someone else do it, and I started to feel the pain as well. Or there are others like who would say, it just hurts if I think about it. And this is completely understandable. This is very sensible to understand the brain has learned to be very good at protecting that person from anything that might be dangerous. So I think it's the perception of the danger levels that's the really important bit. Now, I recently organized the International Chronic Pain Virtual Summit, and we had Professor Tasha Stanton deliver a really interesting talk, and she gave loads of examples of instances where there was no actual damage to the body, but the brain was firing. The brain was made to think like that. So one of the experiments that she talked about was quite interesting. So what they did was they were using a sham laser zap, so a laser machine, and they were going to do zap with that, and that will produce pain. And before they started to do that experiment, they said we'll do initial screening for the person's body areas that they might be more sensitive and less sensitive. And they just created, it was sham, they wasn't doing any actual screening. What they did was just mark some areas they felt, oh, this is fine, this shouldn't have any pain when we put the laser on it. There are some parts of the body, oh, these are definitely, we can't do it here because it is going to produce lots and lots of pain. And then there were third areas which we said, we're not sure about that, maybe it might produce pain, it might be safe here, we'll just have to see. And what they did was they applied laser to the areas which they had categorized as having no pain at all, and then they also applied laser to the areas where they had sort of categorized those as maybe they'll have pain. And what they found was that in the areas which they had marked as maybe having pain, the pain was off the scale. People experienced a lot more pain in the areas, even with sham laser. They didn't really put any laser on it. There was no stimulus going on. But because the people had that anticipation that these areas might hurt, they actually felt a lot more pain in there. So that shows you that your knowledge and your beliefs influence pain, your thought processes influence pain, and thoughts and beliefs and nerve impulses too. So that everything going into the brain is an impulse, it's a nerve impulse. And so thoughts and beliefs are nerve impulses too. And things hurt more when you feel that you're not safe, when you feel that, oh, something is going on there. So, and again, this is from Professor Stanton's work, and she said that in every clinical encounter, we have the ability to add to the safety cues, or we have the ability to add to the danger cues. So we can give the brain message that no, things are safe, things are fine, things are okay, and we can manage those, or we can give them the danger cues. So if someone comes to us with back pain and we just send them to get an MRI scan done without really assessing them, without really understanding the need for it, or the clinical understanding of it, and unsurprisingly, their scan will show a lot of degenerative changes, like mine. I've got a back of an 80-year-old, and you tell them, oh, you got back of an 80-year-old, or we tell them that's the worst scan that I've ever seen. Now, can you put in the chat box and tell me, do you think if it is a safety signal that we're giving, or is it a danger signal that we're giving with that? Can I see the chat box somewhere, or is that hidden?
You can see.
Yes, okay, it's danger signal, yes. So anyone else has any thoughts on that? Is it danger? Is it, yeah. So it is about, we are providing a danger signal to that person saying, oh, you should not be moving because you will hurt your back. You shouldn't be, so that's definitely a danger signal. So, but if we think about it, and we still get that kind of a MRI scan, is there a way that we can provide safety cues? So if we tell them, oh, this is normal degenerative changes, as long as we understand that there is no serious pathology going on, that's the important bit. We still got to look at the red flags and make sure that we screen for the red flags and everything else. But as long as it is non-specific low back pain, if we tell them that, oh, this is just normal degenerative changes, I'll probably have similar in my back, those kind of things, is that a safety cue? Is that a danger cue? That's definitely a safety cue. So it's just about how healthcare professionals are a big part of the problem as well. If we get our messaging right, then we can influence the pain a lot more. And now another thing is emotions can influence our pain significantly as well. So if we are anxious, the same stimulus would hurt more, and you'd learn to associate certain things with anxiety. So environment around us can cause influence of our perception of pain as well. So there's a lot of stuff that goes on. It's not just about the point I'm trying to make is it's not just about the physical, sensory, nociceptive input that we get. It's our thoughts and feelings, it's our behavior, it's our environment, it's our knowledge, it's our environment, the support that we're getting. All of those things contribute to our perception of pain as well. And as long as we continue to have the danger cues being fed into us, then that will continue to keep the sensitivity of that nervous system high. That's going to keep the brain and the alarm system working really high. So another way of looking at the chronic pain is the onion skin model, onion ring model. Now this has been around for a long time, since the 1980s or so, but it has been recently enhanced by Professor Lorimer Moseley and David Butler, and they talk about it in their Explain Pain book. And if you haven't read that book, please go and read that. Every single physiotherapist, every single healthcare professional should go and read that book. I think that's a must read for anyone dealing with pain issues. And so let's go back to the onion skin model. So it's based on the biopsychosocial approach, the onion ring model. It says that even though there might be an initial nociceptive event, persistent pain leads to suffering and subsequent behaviors that are shaped by the external psychosocial and other environmental factors. So at the center of the onion is the nociception, or the initial trigger, which may have caused the acute painful event. Now we do realize that there might be other neurobiological mechanisms going on, the ones that we talked about, the neuropathic and the nociplastic pain, and therefore it might not be a nociceptive event, but it might just be a perceived nociception as well. The next ring is the attitudes and beliefs. So this is really important, as we do not exist, or we don't perceive pain in isolation. So in my PhD research, there was this consistent theme that I found, that people who have a positive attitude towards physiotherapy and who believe that their exercise program would be helpful for them, they would adhere better to the exercise program, and therefore generally they would achieve better outcomes as well. So our positive attitude, our beliefs are really, really important. And in the Chronic Pain Summit as well, we had Dr. Deepak Kumar, who talked about beliefs and use of belief systems and positive reinforcement for our positive beliefs that helps in managing chronic pain. There's also a recent paper that's been published by Professor Peter O'Sullivan in the Brazilian Journal of Physiotherapy, and it's an open access article. It's an amazing article around belief systems, and I'd again encourage you to read that. So, but this aspect about positive attitudes and beliefs can be applied to the pain experience as well. So how often we have seen individuals who have highly positive outlook towards life, they'll come out of an event unscathed. So they might go through a big injury or whatever, but they will recover because they have a positive attitude. They'll do the activities. They'll maintain the belief that they're going to get over it and everything's going to be fine. And it's not just about belief. It's then about following up with the activities and everything else as well that needs to come with it. And that's why I think sports people are really good in terms of adherence and in terms of achieving the outcome. So for them, the motivation to return to field is really, really high, and therefore they will do the activities, they will adhere to the programs, they will have a positive motivation to return to work or return to their sport. While on the other hand, you might have someone who's very laid back and who's very reticent and who's very anxious, and they've had lots of stresses in their life, and they will respond very negatively to a similar kind of pain event, and therefore they will not necessarily recover as well. And okay, so the next layer is suffering, which refers to the personal experience of pain by that individual patient. So what it means in their wider context. And this has been discussed by Dr. Adrian Lau as well in one of the videos. And when he talks about this model and suffering, he gives the example of a marathon runner who trains all year long, bearing adverse weather conditions to prepare for a marathon. Now, if that runner injures his ankle just a week before the marathon, would it be appropriate to have a blasé attitude towards that injury and just dismiss it as a grade 1 ankle sprain? The suffering that person is going to experience, it will augment the pain experience and therefore increase the pain response. So our perception of the suffering, of the distress that comes from pain, can also influence how we respond to pain and how our brain perceives that pain. And the next one is the pain escape behavior. So this ring signifies response of a person to pain, which can again be based on childhood experiences, their social learning, their contextual elements, and the final layer is the social environment. So we do not exist in isolation, unless obviously we are quarantined and we are all stuck in our own houses and we can't go anywhere. We do have a social environment, and we are a product of our social and cultural environment. In some cultures, maintaining stiff upper lip is what is considered the right approach. They won't really discuss their pain, they won't discuss their suffering, they won't discuss their issues with anyone. And that obviously has an impact on how they perceive pain versus the ones who would openly share their issues and they are more receptive to feedback and such. So other social elements such as stigma associated with pain, culture, all of those things help influence pain behaviors as well. So what is the value of understanding of the onion rings model? How can we use it in practice if we think about it? So it can be, first of all, I think it's a very useful tool to explain the pain mechanisms to our patients. So it highlights that at the center of it is the pain neurobiology, the physical factors which can create the pain. But then there's so many layers of things that we can pile on ourselves and the meaning we attach to it, and that influences our experience of pain, our perception of pain, and how our body reacts to it. This was, again, another really interesting way of representing pain, and this was with Dimala Birch in her presentation on mindfulness. And what she talked about was primary suffering, which is the basic unpleasant sensation, like if you have a back pain, the spinal cord injury or pain or whatever, that is your primary suffering. That is the basic unpleasant sensation that you're having at that moment. Your back is hurting. The first thing that happens with that hurt, with that pain, is you start to develop resistance and resentment. It's like, oh, I don't want to have that pain. I don't want that pain. Why am I having this pain? Why me? And then that leads on to the mental, emotional, and physical reactions. So you have the catastrophizing, I can't bear it. The emotional, you have the fear, you have anxiety, you get depression, and then you have the secondary tension, the physical reaction. So there's a secondary element of it. We tighten ourselves. That's the first thing that we do, is we brace ourselves if we are having pain. We are so tight, we are not relaxed at all. and there's resistance to movement. So that cushion thing, she explained a very good cushion exercise. Like the bottommost cushion is the one which is the primary suffering, and then we add layers of cushions, layers of resistance, layers of resentment, layers of secondary suffering onto it. And until and unless we can unpack those, we can take those out, we can remove the outer layers of and suffering and mental and emotional aspects of it, we won't reach to the primary suffering, and we won't be able to address the primary suffering. So what are those sort of external aspects? So there's a ripple effect. So you have the injury, and the injury doesn't work on its own. There's a lot of research around all of these aspects. The pain is associated with sleep deprivation. So there's a cycle that goes on. It can be a vicious cycle. Because of pain, you don't sleep, and because you don't sleep, your perception of pain is, we all stay grumpy, we all stay in a very bad mood if we haven't slept properly. And on my LinkedIn, I shared an article recently around sleep and pain. So if you want to have a look at that, that's available openly as well. And then smoking, drinking, medication abuse, eating disorders, mood. Again, there's that pain cycle. You have low mood, that leads to greater pain perception. Greater pain perception leads to low mood. It's just that vicious cycle. There's also a lot of evidence that suggests that people with chronic pain do have low self-esteem. It's associated with stress, anxiety, depression, PTSD, social isolation, deprivation, all of these things. So these are the layers that pile on as we go along. As a person who's had that initial, so if we think about it, the journey that we've done so far, where we started from was an initial injury. You have the injury, your brain starts to protect you, but then it is protecting you, but it doesn't sort of go back into its normal response state. It remains at a high alert level all the time, and that's in 1 in 4 people. That's a lot of people. It remains in that high alert state, and as it remains in that high alert state, you get all these other things that then pile on the layers onto it, increasing the disability and the impact of chronic pain. I'm just mindful of the time that we are already at 45 minutes beyond that, but we'll get there. So now, once we've considered all these things, I think that's one of the questions that was asked quite significantly, quite a number of times within your sort of registration forms was, can manual therapy help in chronic pain? What sort of manual therapy would help? What would we do? Now, based on what we've discussed, can you answer this question? I will answer this question, but can you put in the chat, what do you think? Can manual therapy help? What do you think? Put in the chat, please. Do you think that manual therapy can help in chronic pain? Yes. Excellent. 1 no. Yes, of course. Okay, yes, it can help, definitely. Wonderful. Short-term effect, yes. Okay, excellent. Right, yes, so this is good. This is really good. Let me go back to, sorry, when I'm reading your chat messages, I got to sort of switch screens a little bit, so let me go back to this. Now, there are 2 things to think of here. We said that the tissue has healed, so in 3 months' time, the tissue is healed, no further healing can take place. So what are we doing with our manual therapy? How can it help? We're not doing anything to the brain, so how can it help? That's one part of it. And I put this question to Professor Peter O'Sullivan and Professor Timothy Flynn recently at the Chronic Pain Summit as well, because I think this has been an ongoing debate for a long time. Hands-on, hands-off. Should we use manual therapy? There are people who will say manual therapy is a waste of time, we should not use it. There are others who will swear by it, and that's fine. Both sides are fine, I think. So I put this question to Professor Peter O'Sullivan and Professor Timothy Flynn, and both of them are recognized experts in chronic pain. And the answer they gave was really interesting. And I've written an article in Physiotimes a couple of months ago as well on this hands-on and hands-off debate and whether it's time for us to reconceptualize manual therapy. So there's a couple of things that were raised. One was, Laying of hands is a traditional ritual. That's what our profession is all about. It is about the hands-on touch. It is about the patient's perception is that we will get some touch, we will get that manual therapy. It's not necessarily the manual therapy, it is about the touch. But also, if we are in private practice and if a patient's coming to you and they are expecting you to do that, and you don't do it, that's going to have a significant impact on the therapeutic relationship that you form with the patient in terms of what you can do for them. And they might not trust you anymore. So I think manual therapy has a really important role in terms of if the patient is expecting it, then it's a good thing to do. It's about, but it's in our own mind, it's about understanding the rationale for why we are doing it. It is not going to treat the tissues. It's not going to heal the tissues. It doesn't do that. In chronic pain, in acute pain stages, yes, it is helpful, and there's a lot of evidence around its effectiveness in acute pain states. But in chronic pain states, it doesn't work. The only thing it does is modulation, providing that support, providing that reassurance, and that's really helpful. That is really useful, because if you think about it, we talked about one of the secondary effects is that we tense ourselves. If someone is experiencing chronic pain, they are in a continuous state of tension. If we lay our hands on them, if we are supporting them, if we are providing that guidance and support, that helps them to relax, then that is a great thing. I think there is a pragmatic solution to it. It's not a yes and it's not a no. It's a pragmatic solution that yes, it does work, but why it works and how it works is different from what we think. It's not effective in terms of reducing the pain per se, but what it does is it helps us to do all the other things that we talked about, that what we can do is to support the patient. So there's, I mean, we can go on and on about this debate as well, but that's all I'll say for now, is don't ignore the pain, explore the pain with them, disarm the patient. It helps to disarm the patient, help them relax, take them back to the things they say they can't do, and with the support, show them that they actually can. So, I mean, that's the reason I think MWM, I'm a fan of that, because you're supporting the body part and then making sure that the person's performing the offending movement within the sort of barriers of pain, and therefore that's the reason it might work, because the patient's feeling very relaxed and supported, and then if they're doing the movement, it's not going to have, the brain's not going to perceive that pain because it's feeling supported. That danger signal's going down. We're giving them the positive safety signal, and that's the important element about it. But I'm happy to discuss that offline again if you want to discuss this further. But that's my take on can manual therapy help in pain. So now we say, and I think it's a similar response for electrotherapy as well. I mean, if you're using laser therapy, someone reached out to me recently saying we are using CEMF and it's really, really amazing and it's got great results. Think about how are you getting the results. Yes, you might get short-term results, but in chronic pain, can you really get long-term results? Can you get permanent results? Are you trying to cure the pain? How can you cure the pain when the brain is in that alerted state? It's about thinking of those things. So what does actually work? So what we found from our review of literature, so based on this, what we tried to do was started work on trying to find out what does actually work for these patients. What's the research say? And these are the things that we've found are really useful in terms of moving the patients forward in terms of their response and recovery and regaining control of their life. One is understanding pain. That's the crucial first step. So pain, neuroscience education. Why do we hurt? Why is the brain perceiving the danger? All of that, providing that understanding to the patients is the first crucial step in the positive treatment outcome. You've got to empower them. Pacing and graded exposure are really important. Again, can you, in the chat, can you tell me if you understand what pacing is? What do we mean by pacing? Any responses? What do you mean by pacing? No responses? Okay, let's go back. No responses to what do we mean by pacing. So pacing is essentially about grading our activities, making sure that we are not providing the flare up. We are making sure that we are, so if say for example the brain comes in at 30 minutes of walking, then when we're starting out, we only do about 50% of that. We're doing it at 15 minutes and then we stop. And then maybe later on we do another 15 minutes and then we stop. So that's spacing. That's about making sure that you're gradually building up the offending activity. And the third thing that works is the biopsychosocial approach. So you got to look at the whole person. That's the important bit. You got to not look at just their offending hand or foot that is hurting. You got to look at the whole person, their social and the psychological constructs and what they're feeling, what they are thinking about pain, and then provide that one-to-one clinical input. That is needed. You can't just provide the pain education and get away with it. Just providing a leaflet or providing a video talking about why it hurts is not going to help anyone get the pain. So what is needed is providing that biopsychosocial approach, and then active participation by the patient is really important. So they need to be engaged, they need to take charge of the situation, they need to be like the captain of the team. And then cognitive functional therapy and acceptance commitment therapy. Let me just put an article, link to an article, or if you just Google it, I think you'd probably still be able to find it. Just search for cognitive functional therapy. There's an open access article, and again, that's a must read for every single physiotherapist. I think read that article, understand. It goes into the details of the assessment, how you would do your assessment, how you would take your history, how you do your examination, and then how you take the patients towards through that graded exposure of the offending movements to get them to start to relax and to get them to start to move freely and to regain control. And that's really, really useful. I found that was probably one of the best articles that I've ever read in terms of managing chronic pain. And then we have the multimodal approach. So what research has shown is that no single approach, just providing ultrasound, or just providing manual therapy, or just providing exercises, or just providing pain education doesn't work. It has to be, because we are looking at the whole person and we're looking at the biological and the psychological and the social aspects of it, it has to be a multimodal approach that we work with. So what are the interventions that actually work? So having appropriate nutrition, diet, exercise. And exercise, I mean, any exercise is good. So there was a recent paper that I again shared on LinkedIn around efficacy of exercises for low back pain, which exercises are effective. And what they found was all the exercises are effective. Any activity that the person is doing is effective. It doesn't matter whether they're doing Pilates or whether they're doing active exercises or whatever. As long as they're doing movement and exercise, that is effective. And that was much better than hands-on treatment, and that was much better than just advice as well. So there's all those elements in there, and I'm happy to share the paper with someone if they want it. You can write to me about that. Again, sleep and rest, we talked about it, that making sure that the person is able to sleep and take away the stress from their activity pacing, hygiene. Providing these activities like hydrotherapy, massage, acupuncture, yoga, these are really useful, really, really useful in terms of providing that short-term window, reducing the stress, reducing the danger cues that are being sent. I think that's the key really, is reducing the danger cues, providing more safety cues. But as long as it is not just acupuncture and not just yoga, it is combined with an understanding of what are the specific issues of that patient, then we can work on that. The psychological interventions, so therapy, counseling, emotional management, music, art, journaling, all of these coping strategies are really, really important. And obviously we are not psychologists, but we do need to understand a little bit about coping strategies. I think that's a really important one for us to understand. And education about pain, recovery, and addiction. These two aspects, at least, we should be able to really provide patients with a good understanding of these aspects. And then the social, having fun, just trying to get a life back, try to do the things that we really enjoy doing, increasing effective communication. Those are the things that work. And we, as physiotherapists, that's our responsibility to make sure that we are supporting the patients in trying to engage with those activities. Once they start to engage with their activities, they will be able to feel the change. They will be able to see the danger signals go down. It is perfectly possible to retrain the brain. It is perfectly possible to rewire the brain. There's a lot of research, there's a lot of functional MRI research that has been sort of taken displays which highlights that with yoga, with meditation, with active exercise, with positive thought processes, with coping strategies, all of these, they change the wiring of our brain. They change the thought process of our brain. They do help tone that signal down, bring that alarm signal, reduce the sensitization, all of those things. One just thought around pain education, though, it doesn't work for everyone. Like manual therapy, it has its role. It doesn't work for everyone, though. So if you have a patient who comes in with like really high levels of pain and they're acute nociceptive pain, acute whiplash, for example, and their neck is stiff and it's really hurting and the back is really hurting, and you sit there and talk to them about pain education, they're going to be like, no, I don't want it. They're just going to throw you out. So it is about screening the patients. It's about understanding so it's about having all those different tools in the toolbox and understanding when to use which tool. That's the important bit. It works a charm with people who exhibit central sensitization, nociplastic pain, chronic pain greater than 3 months, if they demonstrate greater levels of fear avoidance behavior, a lot of catastrophization, and if they are ready to change. All of these things are important for pain education to work. So once we understood all of these things, based on all of these principles, what we did was we created our Restore chronic pain program, which is, we call it the pain team in your pocket. And what we're trying to do is we provide structured 8-week pain education, pain neuroscience education, but we are supporting them with a Restore certified professional, either in person or virtually. We're doing it virtually mainly at the moment, obviously because of COVID restrictions and such, but we anticipate that we'd be able to probably do most of it virtually in any case, even after the restrictions are lifted. And that Restore professional, the pain professional, will usually either be a physio or an OT or a psychologist with special interest in chronic pain. And this is then combined with a 24/7 health coach, which is available all the time. So 24/7, if the patient's struggling in the middle of the night and they're not able to sleep and they are having suicidal thoughts, then they can reach out to the health coach and they'll be able to provide them. And then the app also syncs with the wearable. So if you have a Fitbit or an Apple Watch or Google Fit or any of those things, then it syncs with those as well. And we get objective data in terms of their sleep, in terms of their activity and what they're doing, and heart rate and all of those things, which then again helps the health coach to work with the patient to provide sort of bespoke support to that patient. It's an 8-week program, so it starts with talking about their pain, what is their story, what is their understanding of pain, increasing the understanding of pain, providing them with the resources for change, and then we move on to the focus is on building their resilience, giving them the tools that they have a flare-up plan. No one's probably going to go out of this, if they've had pain for 10 years, no one's going to go out of that 8-week program and say, oh, I don't have any pain at all. But what they will have is they will feel empowered, they will feel that they have all the tools to manage their pain better, they will have the flare-up plan, they will have the resilience to ensure that they can engage with the activities, they can engage with return to work, for example, is a big thing for us. That's in our name as well. RTW is Return to Work Plus. So our focus is helping people return to work, and that's a big focus for us. So that's the 8-week pain program, and it's based on behavioral medicine and neuroscience education. We also engage with the physicians to look at the medication and whether that can be reduced. And in the trial that we've done with about 20 patients, all the patients who were taking medication, they had their medication reduced by at least 50%. Return to work focus and cost savings, all of that is. So the last thought here is pain is a sensation or perception that something is wrong. Yeah, that's the danger signal that's being sent to the brain. And then the brain responds with distress. It's the interpretation that the sensation is terrible, it's awful, it's unbearable. Now, pain is inevitable, but distress is optional. And it's our job as clinicians, it's our responsibility to ensure that we support patients remove the suffering, remove the distress, and they regain control of their lives. We might not be able to cure the pain 100%, but what we do is we empower them, we ensure that they have the ability to regain control of their life and re-engage with their activities and work. So what I would like to encourage you all to do is do a bit of reflection, and obviously you can do this after the call and you can think of it, but as a part of any CPD that we do, I think it is important that we just don't go after the certificate, or I've got the certificate, it's my CPD and that's it. What we need to do is make sure that we reflect on it. What did you learn from this presentation? Did you learn anything at all, really? Or was it something, okay, did it refresh your mind around your understanding of chronic pain? Or can you think of 3 things that you may do differently in helping your chronic pain patients? And what challenges you may encounter in application of this knowledge, and how would you overcome this? I think that there is a great need for us to become reflective practitioners. We need to be thinking about what we are doing, what our personal development plans are, any activity that we're doing, whether it is clinical, whether it is academic, whether it is research, whether it is any knowledge generation that we do. It is important to reflect on what it means for us, how it is going to impact our practice, and what can we do to make ourselves better clinicians. Thank you so much. And any questions?
Thank you, Dr. Devdeep. You have taken us through a beautiful journey, starting from the physiology of pain to the management at the end, chronic pain. It was wonderful, knowledgeable experience. We do have a few questions from the
Yeah, Dr. Sarvajanik, you can continue.
Yeah, we have a question from Dr. Ashish Mathur. What about chiropractic and acupuncture in chronic pain?
Yeah, so I think like manual therapy, I would think of those as something that can help us modulate the pain, that can help us provide that reassurance, it can help us provide that short-term relief. We must realize that manipulating or mobilizing the joints is not going to provide long-term relief. That is an important thing to understand. But what it can provide us is with that short-term pain relief for a period of time, and as long as we understand that ourselves, and as long as we are able to explain it to the patients that this is what the purpose of what we're doing is, for you to be able to then engage in more positive activities. So if someone gives you a 2 days period of very little pain or less pain or no pain, then you use that to do more positive thinking around what is causing the pain, looking at the stressors that are there, and looking at all the other sort of psychosocial aspects as well. So in isolation, I would say chiropractic or acupuncture or yoga or any of these aspects would not work for a long-term resolution. In combination with other aspects, in combination with pacing, in combination with graded exposure, in combination with education, pain neuroscience education, all of these, if they are combined together, then yes, we can use those to achieve much better outcomes for our patients.
Right. Dr. Madhavi has got a question on why does central sensitization occur in 1 out of 4? Is it due to personality traits?
No, so this is just based on the demographic information or the epidemiological information that we have available. So, like we said, we've got about 20% of the population in the world has chronic pain. So that's 1 in 4 is based on that epidemiological data. It's not there's no objective evidence for this. It is based on the epidemiological data at the moment.
Right. So Dr. Sendel Kumar wants to ask, how is movement linked to chronic pain?
Movement is amazing. I mean, we are animals with movement, and that's the main part of it. If we don't move, then we become stiff. and if we become stiff, then we are rigid, and and that increases the pain. So that's whole cycle around being free, being active, being relaxed, and that is what promotes positive health and well-being. So movement definitely is the most important element in terms of making sure that if we have pain-free movement, that's what we want from our life, and that's what we are made for. Hope that answers the question. Sorry.
That's true. Because I mean, one of the most important differentiation between living and non-living is motion. That's true.
Exactly.
Dr. Hiral has a question: how to counsel patients who has learned that they will be having pain lifelong?
Yeah, so I think that is fine. I think that is where it is important to see the difference between pain and suffering. That's where it is important to understand the difference between pain and distress. So yes, you might have some pain, and we all have some form of pain. We get pain here and there, but does it stop us from doing our daily activities? Does it stop us from going to work? Does it stop us from engaging in sports? That's what the challenge is. And if we can gradually move them towards, yes, you might have some pain, but because if they have more, and again, it is related to tracing, it's related to grade exposure. If we can gradually increase their physical activity, it won't happen straight away. It will take a period of time. It might take 8 weeks, it might take 10 weeks, whatever. But the focus of our thing is, yes, you might have pain, but if they're able to do a lot more activities, then I think that they will feel empowered that, okay, that's fine, I can manage it, I have a plan. And I know people who are like pain champions and who are pain experts, and you might know Pete Moore, for example. He's developed the pain toolkit, and that's widely used in the NHS in the UK in terms of chronic pain patients. And in my discussions with him, he says, I'm not pain-free, I still have pain. Yes, you would probably still have pain, but I go biking, I go on long tours, I do all sorts of stuff, I teach, I do all the activities, and I have a really good quality of life. And I think that is the important thing. Not focus on the range of motion and the strength and the pain, focus on the quality of life of that patient. Can we improve the quality of life of that patient?
Right. Dr. Ahuja, they want the name of the book which you mentioned. They want you to repeat the name of the book.
Explain Pain. I think the book I mentioned was Explain Pain by Professor Lorimer Moseley and David Butler.
Explaining pain.
Explain Pain, yeah.
Okay, explain pain. Okay, there's another question regarding the adjunct therapies like taping. Does it help in chronic pain?
I would again say it is probably the same as any other hands-on stuff. I don't see any difference. I mean, taping on its own has not a lot of evidence for it, so I've never used taping, so I'm probably not the best person to comment on its effectiveness in any case. But I don't think it's any different from what I talked about in terms of manual therapy and chiropractic and laser and any of the other interventions.
So we have few more questions, but since it is too late, we'll wind up with one final question. Dr. Vidhi wants to know more about neuroscience education, pain neuroscience education.
I would suggest that Dr.
Sagar, I think you need to mute. Yeah, somebody.
I think I've briefly touched on pain neuroscience education in my talk, but I think if you study the works of Professor Dr. Adrian Lau, he's written lots and lots of articles. I'm happy to send the slides for this as well, and and there's references that I have used from the articles that Dr. Lau has published. He's done a lot of work in pain neuroscience education, and I think that again, Explain Pain is another one that you can go to as well. That's a really good for providing pain neuroscience education as well.
All right. Over to Dr. Sagar. Any questions from your side?
Yeah, definitely. I have one. Thank you, Devdeep, for such a wonderful session.
Thank you.
Yeah, and I have a couple of thoughts or a couple of things I would like your views on. How you see tele-rehabilitation for chronic pain in Indian society? So, you have been to India, and you have done your bachelor's from India. How you see people appreciating tele-rehabilitation for chronic pain in India? That is the first question. And the second is, how you design, let's say for example, one clinician is there, and there he has got a patient of chronic pain. How you see design a protocol for them such that how you design a sessions, that it would be weekly sessions, or what would be the intensity, frequency, and the duration of the sessions for the clinical practitioners to be designed as?
Okay. Yeah, thank you. I think those are both really very relevant and very important questions. Yes, I've been in India for the first 27 years of my life. I was in India, and obviously India is my country. I'm still an Indian. Nothing's changed in that regard. And I know it is quite difficult, and I think the challenge is around health literacy. That's the first bit. But also it is about the availability of the IT technologies in rural areas as well. Yes, it has improved significantly, but has it improved enough in terms of able to deliver consistently? So there's a lot of work to be done. I wouldn't say that we are there yet in terms of being able to deliver pain neuroscience education and such remotely at this stage. Perhaps in Delhi and other metros we are okay with that, and there would be people who would perceive that and they'd be receptive to that. But I think there's a lot more work to be done in terms of health literacy. I think one of the biggest challenges that I see is, and that's no sort of stereotyping, but that's just my own perception from my own family members and everyone that I know, is there is an external locus of control in Indian society. We go to the doctor, I'm here, I'm going to pay you the money, you fix me, right? I'm not going to do anything myself. What I want to do is give me the injection, give me the medication, manipulate my back, do something, but you are the one who's got to fix it for me. They are not ones who are like, give me all the information and I'll do it myself. It doesn't work like that in India, and I'm sure you'll agree with that. That's probably your experience as well, right?
True.
Yes. So I think that there is still a long way to go in being able to deliver telehealth and tele-rehab, especially in the rural areas of India. Yes, in the educated metropolitan elite, it is possible that they'll be more receptive to it. The second question that you'd asked was around the frequency and deciding what is the appropriate frequency and intensity of the program and how many sessions we want to give and such. So the program that we are delivering at the moment is structured around pain neuroscience education. So we give structured 8 modules. So they have 8 different weekly modules. So they got to go through about 1 hour of pain neuroscience education every day. So that's on them. They've got to go through those modules. We are not going to do anything about that. But what we do is we provide 2 hours a week to that client, and that is dependent on how proactive that they are. So some of the people are going to be very proactive, and we give them the tasks and we agree these are the goals, this is what you need to do, and they go and do it, and therefore we see them once a week. We don't see them anymore. There'll be others who've got really heightened state of sensitivity. They're really stressed out, and they need a lot more hand holding. They need a lot more support, and maybe we'll have a 15-20 minute session with them every day. So we're still going to do about 2 or 3 hours a week, or we will probably give them like daily sessions just to provide that support and make sure we set daily goals for them. So like, if we see that they don't have the internal locus of control, then we'll provide them with that guidance and set daily goals. So these are the things that we want you to do between today that we're talking and tomorrow. Can you do these things? And we'll review how much progress you have made. So it is very bespoke. As I said earlier, it's not just about throw the education at them, give them the videos, and then they'll do everything and it will be fine. It won't work. What you need to do is, and that's where your clinical input is really important. That's where your clinical insight is really important in understanding what are the contributing factors to their pain. What is causing that pain? So yes, they have a heightened state, but what is causing that heightened state? And that's why you need to delve deeper into their story, try to understand their pain, their society, the whole of the biopsychosocial paradigm. And once you can understand that, then you can see, oh, these are the factors. This person's really stressed because of his work. This person's got, he wants to go back to his sport or his team, or he wants to return to football, or those kind of things. So you got to look at the actual specific factors which are causing the pain, which are causing that stress to that person, and then address those specifically. So it can be quite bespoke. It can be 15-20 minutes a day. It can be 2 hours every week. It depends on the client, I think.
That's great. I mean, it was quite a good explanation. Thank you, Dr. Devdeep, for sparing all your time. And it was a completely engaging and knowledgeable session for all the physiotherapists practicing, because pain is something which is inevitable, as you said. So it would be definitely helpful for our therapists to understand pain, as you rightly said, so that we can handle patients with chronic pain. Thank you so much for a wonderful time.
No problem.
It's a pleasure to associate with you for this webinar.
Thank you so much for inviting me. Thank you. I'd love to share my experience. Thank you.
Our pleasure.
Thank you so much, Devdeep.
Yep. Thanks, Sagar. Take care, mate.
Yeah, thank you so much.
Cheers. Bye.